Hello everyone. In this lecture, I am going to talk about very concise and to the point description about the management of abortion here. So before you watch this video, I'll suggest you that I have made the videos regarding the classification and the causes of abortion. So you can go through with this all content, and the link of that video are given in the description box below. So before we proceed with the management part in abortion, a very important thing is that however we manage the abortion, whether it is spontaneous miscarriage or whether it is induced one, in either of the abortion type, the emotional aspect is equally important. It means we support the woman psychologically as she lost her baby. So the psychological support, whether it could be given by a family or friends, or it may be by the trained practitioners, that is the doctor or nurses, is equally important, as they must be given up appropriate information, the relevant information regarding the abortion process, why it was happened. So this all can relieve her stress up to a certain level. So let me talk about the spontaneous miscarriages first. So suppose if the chromosomal abnormality, as we talked about it earlier, that the chromosomal abnormality is one of the important reasons behind the abortion. So if the chromosomal abnormality we found in the previous pregnancy by the karyotyping of parent or the fetus, then we can give genetic counseling to the parent, that they can adopt IVF technique, in vitro fertilization, where they can receive the donor gamete, and before implantation also they can go through with the pre-implantation genetic diagnosis, where they can detect any chromosomal abnormality before implantation, and they can proceed with the pregnancy further. Now if we found that the abortion is because of any endocrinal issue, suppose if she had diabetes or obesity, thyroid abnormality, luteal phase defect, or PCOS, polycystic ovarian syndrome. So if the abortion is because of any of the reason, then we can give periconceptional supplements to women. So periconception, it means we are giving drugs or supplements before she conceives next time, before 3 to 4 months. So she can be cured with these all things, and she will have normal endocrinal function before she conceives next time. So periconceptional supplementary therapy with the use of drug is also essential for any of these endocrinal problem. So I'm not going in too detail because these all are too big to deal enough. So this all will be discussing in another video separately. So endocrinal issues can be sorted by supplementary drug therapy before she conceives next time, and in periconceptional period itself she will receive these all supplementation. So thereby it can be cured her endocrinal issues. Now if the reason behind the abortion is the APLA, antiphospholipid antibody syndrome, then it is treatable. What we have discussed in APLA is that there is a formation of thrombus in the blood vasculature. So this thrombus can be relieved by the use of combination of two drugs. So here we can use aspirin and heparin once the pregnancy is confirmed by UPT, urine pregnancy test, or once the cardiac activity started in the fetus. So once we are assured with this all thing, we can administer aspirin or heparin combinedly to a woman throughout pregnancy till the pregnancy reaches term. So by these two drugs, this condition can be treatable, as it is anticoagulant. It breaks the clot that can be formed with this disease condition. So here aspirin, the low dose aspirin can be administered 60 to 80 milligram daily orally, and in combination with that 5000 unit of low molecular weight heparin subcutaneously twice a day can be administered with a combination of aspirin. So these two drugs we combinedly administer to a woman throughout pregnancy till 37 week of gestation, or once the labor started. So once the labor started, we can hold the heparin 24 hours before that, and aspirin can be discontinued 5 to 10 days prior to the onset of labor. And once the woman delivers, after 6 to 12 hours, we can resume back with these all drugs. So these all anticoagulant, the heparin and aspirin, treat this APLA syndrome, and the combination of this drug gives a good result with the pregnancy outcome. Okay. Now, if the reason of abortion is structural defect, suppose if bicornuate uterus or septate uterus is the reason, then we can perform unification procedure, where the condition in bicornuate in septate uterus, what happened, there is 2 uterine cavity, there is a septa or there is a division, and there is a 2 uterine cavities. So by the use of unification procedure, where we can make the uterine cavity, we can change this uterine cavity into a single large cavity, we can advise a woman to go through with the hysteroscopic metroplasty, where the septa or the division that divide the cavity will be removed and make this whole cavity to become large and single one. And suppose if the woman had Asherman syndrome, where the scar formation is more, and if she had fibroids, leiomyomas, then hysteroscopically resection or excision of these fibroid and scar could be done with the mean of surgical management, and that can improve the outcome in subsequent pregnancy. So the structural defects can be managed by the surgeries. And suppose if the woman had cervical incompetence, where the cervix get weakens and it dilates prematurely, thereby the fetus and the membrane comes out through the vaginal route. So in cervical incompetency, there we can manage it by using a tape or the suture around the internal os. Okay, so during pregnancy itself, we can use sutures and the tape that can reduce the diameter of cervical canal, and thereby the pregnancy can reach up to the term. Okay, so here basically 2 procedures are there. One is McDonald and Schrodinger's procedure, the another one. So in either of the procedure, the principle behind the procedure is same, that is just wrap the tape or the suture around the cervical canal at the level of internal os and reduce the diameter of cervix, thereby it can hold the pregnancy and reaches till term. Okay, but in both of them, the most common technique which is being used is the McDonald technique or the procedure, where the bleeding is less and it requires less technical skill. So here in this procedure, what we do, we take non-absorbable suture material from anterior wall, we take deep bites approximately 4 to 5 covering the lateral and posterior aspect, and then come anteriorly. So these 4 to 5 bite, that is in and out suturing, is to be done in purse string manner, and then once these both lining, the both ending of suture come in front anteriorly, then snugly hold this both the endings, and by reducing the diameter of cervical canal, and finally we tie it up on anterior aspect. Now in Schrodinger's procedure, what we do, we use non-absorbable suture material, that is muslin tape, and will give incision on anterior and posterior aspect. Then we'll passes this muslin tape along the wall of cervix, that is submucosally, and from anterior to posterior the tape is being passed, and then on posterior aspect will tie both the ending of tape. Snugly will hold the sutures, the tape, and then will tie posteriorly. So this requires more technical skill, as we are giving incision on both sides, so it bleeds more. Okay, so that's why it is performed less in comparison to the McDonald procedure. So both the procedures have the same principle, that it holds the cervix, it reduces the diameter of cervical canal, and thereby the pregnancy continues till term. So thereby we can manage the cervical incompetencies by the use of these procedures. So once the pregnancy reaches till term, that is by 37 weeks, or whether the onset of labor begins. In either of the condition, we can remove the stitches, because thereby the cervical canal would be dilated and the delivery could be taken place. So this cervical cerclage procedure we can done in between 12 to 14 weeks, and that can be done 2 weeks priorly from the previous fetal wastage. Suppose if the woman had abortion previously on 13th week, okay, then now this time we can perform this procedure at 11 weeks, 2 weeks priorly, but it should not be done in less than 10 week of gestation, because by the 12 to 14 weeks we can rule out any other causes for abortion, and then thereby we can make cerclage procedure. Now if the reason of abortion is the sepsis, it means what is septic abortion? That is the infection in the uterus or in the conceptus. Okay, so if any type of abortion that shows the feature of infection is called septic abortion. So septic abortion can be because of aseptic techniques, it can be because of the retained tissues or the conceptus, that is incomplete evacuation of the uterus, something left remain in the uterus, that may be the reason of sepsis, and that can be because of any genital tract injury, especially in the bowel region. So in either of the reasons, once the infection ascends in the uterus, or it may be goes beyond the uterine cavity, that can cause septic abortion. So majorly the organism that causes sepsis is usually present in the normal flora of vagina. That could be aerobic or anaerobic. So these may ascend because of these all reasons as I have mentioned. So the woman may shows the features of infection like fever, she may have purulent vaginal discharge, she may have pain, and uterine tenderness could be seen. So these all signs can be seen with the feature of infection. So once we assure that the woman have septic abortion, the features of infection with the abortion, then only management that we can done is the administration of broad spectrum antibiotic that work against any of the gram positive and gram negative microorganism, and we can evacuate the uterus, because sometimes incomplete evacuation of the conceptus can be the reason. So we can evacuate the uterus and remove all the part of conceptus that remain inside the cavity. So evacuation could be done, and broad spectrum antibiotic we can administer intravenously. So these are certain causes behind the isolated and recurrent spontaneous abortion, and depending on the reasons, the causes, they can be managed. Now if the abortion is induced one, where we are deliberately terminating the pregnancy, then how we can manage and what all medication and the surgical intervention we can perform. So while we are deliberately terminating the pregnancy, behind that there is only the two reasons. So any pregnancy that can alter the mental status of woman and that can make her life in danger is the main reason for MTP. And if we detect any congenital anomalies or any mental defect in the fetuses, then also we cannot continue the pregnancy till term, because altogether it will create a danger of life of the fetus itself. So altogether mother and fetal life are equally important, and if it get hampered, then the continuation of pregnancy cannot be possible. So that's why we'll terminate the pregnancy legally or by means of induced abortion. So here there are various methods of induction of abortion, and we can use medical method and surgical method. Medical, where we use certain medication. Surgical, by means of various invasive procedures, we can remove the part of conceptus. Okay. So in first trimester, because in first trimester what happened, the size of the fetus is not that much big. So by the week of 7 to 9, as per the government rule, we can terminate the pregnancy by the use of medication itself. So the medicines that we are using in first trimester for termination of pregnancy is the combination of two. One is mifepristone and the another one is misoprostol. Mifepristone is anti-progesterone drug that is progesterone antagonist, and misoprostol is the prostaglandin E1 analog. So mifepristone, how it works? Mifepristone blocks the receptor in the uterine wall regarding the progesterone. So we know the progesterone requires throughout pregnancy for the maintenance, and once the receptor get blocked, it will not nourish the fetus further, and thereby it will kill the baby. Okay, so the pregnancy will not be continued further by the anti-progesterone drug. Misoprostol, it creates uterine contraction and it prepares the cervix for dilatation. So cervical softening and uterine contraction is the action of misoprostol. So in first trimester, by 7 to 9 weeks, the medication alone can terminate the pregnancy. So in this medical management, 200 milligram of mifepristone orally we can administer to a woman, and 24 to 48 hours later we can administer misoprostol about 400 to 800 microgram, and that can be administered by various route like sublingual, oral, vaginal. Okay, but the most preferable route is sublingual, that is placing the drug just beneath the tongue, and the vaginal route. Okay, but once the week of gestation advances in first trimester, the medical management alone is not enough, because the size of the fetus is too big to deliver out. So in combination with the medical management, we perform certain surgical intervention to terminate the pregnancy. So the surgical management that we done in first trimester is the suction and evacuation. So the suction, it means we are creating a vacuum and evacuating, emptying the uterine cavity. So the vacuum can be created by two. One is by the manual method and another by the electric machine. So this could be done by two, MVA and EVA. MVA, that is manual vacuum aspiration, where we can use a 60 cc syringe and we can create a vacuum, and after creating a vacuum we can attach one cannula on this syringe. The cannula which is being attached is the Carman's cannula, and that comes in various sizes. Depending on the week of gestation, we can select that particular size, and in same manner we can use electrical vacuum aspiration machine, where electrically we can generate the vacuum, and same Carman's cannula we can attach and suction all the content. Okay, so suction and evacuation is the surgical intervention where we can suck all the conceptus, the product of conceptions, from the uterine cavity and evacuate from the uterine cavity and make it empty. So this is the surgical intervention that we can done in first trimester. Now in second trimester, again we can use medical and surgical method. In medical method, we can select the combination of these two drugs as I have mentioned in the first trimester, that is mifepristone and misoprostol. But here we can give mifepristone about 200 milligram orally, and 24 to 48 hours later we can administer misoprostol, but the doses varies, that is approximately 400 microgram. Sublingually or vaginally we can administer, and we can repeat this dose 3 to 4 hourly, and maximum up to 5 doses we can administer. So here we are increasing the doses of misoprostol here as the size of the fetus is big in second trimester. Okay, but again if the week of gestation is more, suppose 18 and 19, then in these week of gestation the medical management alone is not enough. So here we can surgically intervene the abortion process. So suction and evacuation could be done, but as the fetal size is too big to deliver out through this narrow suction tube, it is not enough. So we can use dilatation and evacuation procedure. So before dilatation and evacuation, we can administer cervical priming agent. That before dilatation we can prepare the cervix to be soft and dilate. So certain cervical priming agent we can administer. So the drug that I have mentioned, that is mifepristone and misoprostol, that we can administer, and that help in dilatation of cervix, and then we can evacuate the content. Or whether we can use certain hygroscopic dilators, in which laminaria tent or dilapan can be used. So when we are taking this hygroscopic dilator, we can put these dilator, either of the dilator, in the cervical canal and place it overnight. So what they do, they absorb water which is present in the cells in the cervical canal. So once they absorb cells, they swollen up. So once they swollen up, they dilate the cervix slowly. Okay, so overnight with these all hygroscopic dilator, the cervix get dilated, and then next day what we can do, we can remove this hygroscopic dilator and dilate further if required. By the metal dilators, we can use Hagar dilator or Hawking-Ambler dilator. So these metal dilator can be used to dilate further, and once the cervix get dilated, we can evacuate the content. So for evacuation, the suction is not enough. The cannula is not that much sufficient to deliver out these all large product of conceptus, because these are too large that can be stuck in the tube. So by the use of ovum forceps, we can remove or evacuate the uterine cavity. So this is the dilatation and evacuation process, and in dilatation we can use either the hygroscopic dilator or we can use cervical priming agent, the medication that help in dilatation of cervix. So in second trimester abortion, we can use certain other drugs like prostaglandin E2, dinoprostone, prostaglandin F2 alpha, that is PGF2 alpha is carboprost, oxytocin, KCl, methotrexate. These are the other drugs, but the effectiveness of the mifepristone and misoprostol is more. So these are widely used. So here in this lecture, we have discussed with the management, whether it is by the spontaneous miscarriage or it may be by induced deliberately terminating the pregnancy by MTP. Thank you.